Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through endocrine pharmacology. Let's go ahead and start off with talking about a few different hormones, some basic physiology and pathophysiology. We're going to start with talking about growth hormone. Growth hormone is responsible that it stimulates growth and cell reproduction. If you don't have enough of this, you end up with short stature. If you have too much of this, you're diagnosed with acromegaly. To assess for this, we use the lab GH, or growth hormone, which is a lab we can check. Next hormone we're going to talk about is ADH, or antidiuretic hormone. This is responsible for increasing water reabsorption in the renal collecting ducts. In layman's terms, it pulls water out of the nephron so that the water, instead of going out of your body via the urine, comes back into central circulation. If you have too little of this, you end up with diabetes insipidus, where the patient ends up peeing excessively. If you end up with too much of this, you have SIADH, or syndrome of inappropriate antidiuretic hormone, in which case the patient holds on to too much fluid. The lab to assess for this is going to be at ADH level. Next, we have the ACTH, adrenocorticotropic hormone. This is responsible for regulating metabolism, stress response, and inflammation through the usage of steroids and cortisol, which is one of the steroids. In regards to this one, if a patient has too little, they end up with Addison's disease. If they have too much, they end up with Cushing's syndrome. If we're going to check a lab for this, we can check a ACTH, a cortisol level, in order to get an idea of how the patient's doing. The next hormone we're going to discuss is going to be thyroxine, which is also known as T4. This is one of the thyroid hormones, and this one's responsible for regulating metabolism, energy production, and growth. If a patient has too little of this, they end up with hypothyroidism. If they have too much of this, they end up with hyperthyroidism. Now, you may see some other terminology here as well. There's a diagnosis of Hashimoto's thyroiditis. That's an autoimmune condition, and it's one of the most common causes of hypothyroidism. So you may see that referred to as hypothyroidism. We can also end up with hyperthyroidism being called Graves' disease. Now, there's two additional terminologies you may hear. A myxedema coma is a severe manifestation of hypothyroidism, and thyroid storm is a severe manifestation of hyperthyroidism. Now, obviously, the lab we would assess here is a T4, which is thyroxine. If it's low, the patient is hypothyroid. If it's high, the patient's hyperthyroid. However, there's one thing that gets tricky here, because the most common lab that we use to assess the thyroid is actually not T4, it's TSH. TSH is thyroid stimulating hormone. This hormone is responsible for stimulating the production of T4. However, this is what's called an inverted lab value. What does that mean? When the TSH is high, the thyroid production is low. And when the TSH is low, the thyroid production is high. Before that gets you confused, think about this. TSH stands for thyroid stimulating hormone. The thyroid needs to stimulate the production when production is low. So if there's a lot of stimulation, that means production is low. So when the TSH is high, the patient has hypothyroidism, and obviously the other way as well. Lastly, we're going to talk about calcium, and obviously at the end of this lecture, we'll get into a whole bunch of diabetes, but right now we're talking about calcium. This is not a hormone, but it's controlled by two hormones. It's controlled by PTH. PTH is the way the body increases the serum calcium level. Calcium is mostly in our bones in our body. I think roughly 99% of all the calcium in our body is in our bones, but we do have a significant and extremely important amount in our blood. If that level is not kept exactly in check, we can end up with a lot of issues such as cardiac dysrhythmia. So in order to keep that level, the blood level of calcium perfectly balanced, we have parathyroid hormone, which the body releases to bring up the calcium level in the blood. And we have calcitonin, which the body releases to bring down the calcium level in the blood. And I did detail here exactly how these medications go about increasing and decreasing the serum calcium level. Next, let's go ahead and talk about the specific hormones. First, we're going to start with growth hormone. Growth hormone, if a patient has a deficiency in growth hormone, we can give them growth hormone. It's called somatotropin. This stimulates the growth of all tissue, as we mentioned just a few minutes ago. We use this for short stature and for growth failure, and the side effect here is hyperglycemia, and this only comes parenterally. There's not a whole lot that we would test on the nursing level about this drug, so let's move on. That was for too little growth hormone. What about too much growth hormone? For that diagnosis, for acromegaly, we have octreotide. Octreotide inhibits the release of growth hormone, and it's actually also used to treat diarrhea. The most common adverse effect or side effect is going to be GI issues, and this is also available parenterally. We also have a drug called pasireotide, which is also used for acromegaly, but it's also used for Cushing's disease. Next, we have ADH, or antidiuretic hormone. Again, we said if you have too little of this, you end up with diabetes insipidus. Too much of this, you end up with SIADH. So let's start with diabetes insipidus. If you have too little ADH, we treat you with ADH, with antidiuretic hormone. But we're going to have to break this drug class into two very distinct subclasses. First, we're going to talk about vasopressin. Vasopressin is ADH. It reabsorbs water from the filtrate like it's supposed to, but it also has a second overpowering action, and that is vasoconstriction. Vasopressin is a drug that has very powerful vasoconstriction properties. So because of that, we don't really use it for diabetes insipidus. We do use it for shock and cardiac arrest. And because of how powerful it is with vasoconstriction, it can cause hypertension, it can cause arrhythmias, and obviously because it does hold on to fluid, it can cause fluid retention. This is an IV only or IVIM only medication. Now let's talk about the actual ADH that we would use for diabetes insipidus. That would be desmopressin or DDAVP. This is used for diabetes insipidus. It's also used for nocturnal enuresis, which is nighttime bedwetting, von Willebrand disease, and hemophilia A. This medication does not have the vasoconstriction effect like vasopressin. This does have side effects of hyponatremia, fluid overload. Again, it's getting you to hold on to fluid, so that makes sense, as well as a headache. And this one's available both parenterally and PO. So now we talked about too little of ADH. What about if I have too much of ADH? Too much of ADH, the body's going to be holding on to fluid. We don't have a specific endocrine drug for this because the answer here would be diuretics. The treatment for SIADH, if the patient is holding on to too much ADH, too much fluid, then we would give them diuretic to get rid of some of that fluid. Next, let's move on to the steroids. If a patient has Addison's disease, if they have too little steroids in their body, we could treat them with steroids. We've already discussed steroids at length in the anti-inflammatory and pain management lecture, so I'm going to go through it pretty quickly over here. The drugs are hydrocortisone, prednisone, methylprednisolone, and others. These work by suppressing inflammation, suppressing the immune system, and suppressing adrenal function. Why do they suppress adrenal function? Because they do the job of the adrenals. If the job of the adrenals is to produce steroids, and this drug is actually steroids, the body has no longer a need to produce it, thereby suppressing the production, suppressing the adrenals. What do we use this for? We use it for a bunch of things. But right now in endocrine, we're just talking about adrenal cortical insufficiency and Addison's disease. And I'm not going to get into the whole list of other things that we use steroids for. We have seen steroids in the past, and you should know that in this case, we are giving the steroids systemically. We don't have the option of giving it topically or inhaled or something like that when we're treating Addison's. It is steroids, so we get the full adverse effects of steroids. We get that immunosuppression, that hyperglycemia, hypertension. Remember, for every single one of these on the list, you have to understand how you need to educate your patient. Immunosuppression, you need to educate them to stay away from people that are sick or take extra precautions or report if they get a fever. For hyperglycemia, you need to educate them that they may need to lower the sugar in their diet or increase their insulin if they're diabetic. For every one of these extensive adverse effects, this is why we don't like giving steroids systemically. You're going to get those with this treatment because Addison's treatment is systemic steroids. Next, systemic steroids must always be tapered. We covered that in the past. It certainly applies here. In fact, not tapering your steroids is one of the leading causes of ending up in adrenal cortical insufficiency. That's the whole reason we tell you that you have to taper it, because again, like I said, the adrenals are suppressed because their whole job is to produce steroids. But when I give you steroids, you have plenty in your system. So the adrenals go to sleep. If you don't slowly taper down, if you suddenly stop taking it, the adrenals are still sleeping. There's no steroids in your body, and you end up with adrenal cortical insufficiency. Next, I want to mention just a quick note. There's a drug called cosentropin. This is used for diagnosing adrenal cortical insufficiency and determining its root cause. That's all you need to know about that. Next, let's move on to the treatment of the next hormone. And now we're going to talk about ketoconazole. Ketoconazole is actually an antifungal medication, and this is used to treat when we have too much steroids in our body. In this case, it reduces cortisol and androgen production. We use this for fungal infections, and we also use it off-label for Cushing's syndrome. This does have adverse effects of hepatotoxicity as well as GI issues, and a black box warning for hepatotoxicity, plus a black box warning that in combination with multiple medications, this can cause QT prolongation. Next, we're going to move on to the thyroid. The first medication we're going to talk about is levothyroxine. Levothyroxine is one of the 10 most prescribed medications in the United States. Hypothyroidism is very common, and this is the drug that we use to treat it. Levothyroxine is essentially thyroxine, which is T4, which is the most active of all the thyroid hormones in terms of executing the goals of the thyroid. This medication comes in doses as small as 12.5 all the way up to 300, which is very uncommon, but we do that because we need to get the dosing exact. For that reason, we're going to be messing around with their doses for quite a while until we get their thyroid levels exactly in check. We're probably going to be checking their labs every 4 to 6 weeks when we first started treatment, and then we're going to keep checking it every 6 or 12 months once we stabilize their numbers. Generally, if a patient is taking levothyroxine, they're going to take it for the rest of their life because they have hypothyroidism permanently. It is safe to take in pregnancy, so that doesn't become a concern if they become pregnant. Generally, we tell patients to take this in the morning, and usually we tell patients to take this before their first meal of the day. This does have a black box warning that's not to be used for weight loss. You may be familiar with the different signs and symptoms of hypo and hyperthyroidism. and hyperthyroidism, which if you take levothyroxine, you can end up hyperthyroid. Hyperthyroidism can cause an increase in energy and weight loss. Those both sound like good things, but not if you're abusing levothyroxine to get those results. It can have tremendously bad side effects. Next, anytime you're treating a patient for levothyroxine, this goes for basically everything we're treating a patient for, certainly in endocrine world, you always need to monitor for the signs and symptoms of the underlying condition. So if I'm treating you for thyroid issue, I'm going to assess for the signs and symptoms of hypo or hyperthyroidism, like your pulse. Remember, a pulse will be really high in hyperthyroidism, so I'm going to check your pulse. Weight gain, feeling cold, things like that. I'm going to go ahead and I'm going to check those signs and symptoms in relation to my treatment. Next, if patient is hyperthyroidism, and hyperthyroidism can be treated with methimazole or PTU, which is propylthiouracil. The mechanism of action here is that these block the synthesis of these thyroid hormones. The indication here is obviously hyperthyroidism. PTU specifically has an increased risk of developing hepatotoxicity. Methimazole cannot be taken in the beginning of pregnancy. So if a patient is on that medication and become pregnant, we're going to switch them to PTU. However, we would usually switch them back to methimazole in the second and third trimesters. Next, we have two medications that can be used in specific situations of hyperthyroidism. One is potassium iodide, which is called glucose solution, and sodium iodide. These are used to suppress the thyroid prior to surgery and also to treat thyroid storm. And then we also have radioactive iodine, which is used to treat hyperthyroidism and thyroid cancer really quick. The first ones, the potassium iodine and sodium iodide, they flood the thyroid with iodine. When there's too much iodine, the iodine is not able to do its job. The second part, the radioactive iodine, that medication works by actually killing off part of the thyroid. Next, we moved on to calcium. Remember, we said if a patient has a low calcium level, the body's going to release PTH to bring that serum calcium level up. We don't give a patient PTH if they have a low serum calcium level. We simply give them calcium. But when we give them calcium, which is discussed in the fluid and electrolytes lecture, we're also going to give them vitamin D. Vitamin D is known as calcitrol, and this works by helping the absorption of calcium. When a patient is being recommended to take calcium, especially if it's for severe hypocalcemia or something like that, we would almost always give them vitamin D along with it. Now, on the flip side of that, if a patient has a high serum calcium level, we would give them calcitonin, just like the body would release calcitonin in response to that. Calcitonin would be used for that hypercalcemia that I just mentioned, but it's also used for Paget's disease and osteoporosis. Why? If you remember from the beginning of this lecture, when I mentioned how calcitonin works, I said that it reinforces the calcium in the bone so that it basically takes away calcium from the blood and gives it to the bone. Reinforcing calcium in the bone is great if a patient has osteoporosis or Paget's disease, which is why it's used for that. And finally, calcitonin is a salmon-derived product, so be careful giving it to patients that have those allergies. Now let's jump into diabetes, and we're going to spend the rest of the lecture, about 10 or 15 minutes, talking about this. So first, let's go through some basic key concepts of diabetes so that we fully understand what we're talking about when we get to the pharmacology. Type 1 diabetes is an autoimmune disorder. It's where the body has attacked its own pancreas and destroyed the pancreas and its ability to produce insulin. What do we need insulin for? Very simply, every single time we eat, our body absorbs the sugar out of our meals. The sugar goes into the bloodstream. Our body must maintain a very tight control of the sugar level in our blood, of our serum glucose levels. So if that level ever gets elevated, the body, the pancreas specifically, releases insulin. The insulin goes up to the sugar that's in our blood. It grabs onto that sugar. It walks up to a cell. It walks into the cell. And now that sugar is no longer in our blood. So our blood sugar level comes down so that it stays within range. In a healthy patient, we try to have a fasting blood glucose level somewhere around 70 to 100, 70 to 126, 70 to 110, whatever your specific textbook says. I've seen all of those in my review of the different nursing textbooks. And that's where we want to be fasting. Once we've eaten a meal, when our body's working to bring it back down, we still really never want to see a blood sugar above 180. There's a very rough rule of thumb that if a patient ever has a blood sugar above 180, they probably have some sort of insulin resistance, because the body's usually pretty good, even with a really heavy sugar meal, of keeping the sugar level below 180. So that's the purpose of insulin. That's why we need insulin. So that's type 1 diabetes. We don't have insulin. Type 2 diabetes is different. Type 2 diabetes is the person eats their sugar meal, the sugar gets absorbed into the blood sugar level goes up, the pancreas responds, it produces insulin. The insulin does its job. It walks up to the sugar, it holds hands, and it goes to the cell to get out of the blood system, but the cell is resistant. The cell does not open the door. The cell says, no, you are not coming in. So now the sugar and the insulin are staying in the blood and not coming into the cell. So since the sugar is staying in the blood, the sugar level stays elevated. And that's the problem of insulin resistance. This is not an autoimmune disease. This definitely has some genetic component to it, and it certainly has a lifestyle and obesity component to it. Next, let's talk about a few more things. So now we understand the basic pathophysiology of type 1 and type 2. Let's talk about hypoglycemia. If a patient's sugar gets too low, because all of what we're going to talk about pharmacologically is if a patient's sugar gets too high. But hypoglycemia, we'll spend a minute talking about that. If a patient's sugar gets too low, the first and most desirable treatment is to give them oral glucose. You can give this through a cup of orange juice, or they have oral glucose tubes where you just put it on the side of the patient's cheek. The number one most important thing to understand is the patient must be conscious, alert, oriented, able to swallow in order to use this treatment option. If they are not any of those, you cannot use this treatment option, and we have to move on to the next step. The next step would be either IV dextrose or IM glucagon. In most cases, if the patient has an IV or you can readily establish an IV, then IV dextrose would be your best bet. If you're unable to establish an IV or for whatever reason or multiple attempts, then we can go ahead and do IM glucagon. IM glucagon is it's a little kit that you have that you just put it together. So that's how it's not really I won't get into it further than that, but that's another option. It's a very expensive option. It costs about 100 times more than a dose of dextrose, which is why we don't prefer to use that. Next, the body releases insulin in response to a high glucose level. We talked about that. We didn't mention that the body also needs to make sure the sugar doesn't get too low. In response to that, the body releases glucagon into the bloodstream to get our sugar level up. Treatment of diabetes is monitored. When you are actively treating a patient that has diabetes, we monitor their treatment or the progression of their treatment via either a finger stick glucose level or a lab glucose level, or most importantly, an A1C. So let's talk about those real quick. A blood glucose level, we already said a fasting blood glucose should never be above 126. And then we have an A1C. A1C is considered the gold standard in how we assess a patient or monitor a patient or diagnose a patient with diabetes. What numbers are we looking for? In A1C, we want it to be 5.7 or below, or I think some places say below 5.7. And then 5.7 to 6.4 is sort of that middle stage. Some places call it prediabetes, some places call it borderline diabetes. 6.5 and above is universally considered diabetic. However, when a patient is a known diabetic and is being treated for diabetes, don't get confused here. Now, our goal of treatment is to get their A1C below 7. We want to get it below 7 and keep it there the rest of their life. So one more time, to diagnose, we want it, a diagnosis is made with an A1C of 6.5 or above, but once they are diagnosed, we want to keep them at 7 or below. Obviously, the first line treatment for all of this is going to be lifestyle modifications. There's no amount of medication we could give a diabetic patient that will overcome a bad diet, so they have to be educated on that. When a patient's being diagnosed, I mentioned the A1C and I mentioned glucose. I didn't mention the third method, which isn't really pharmacology related, but you may still see it on some exam, and that is an OGTT, an oral glucose tolerance test. This is very common, not very commonly, this is universally done in patients that are pregnant somewhere around the 20 to 24 week mark to check for gestational diabetes. Next, let's talk for just a second about DKA and HHS. DKA is diabetic ketoacidosis, and HHS is where a patient has a very high sugar level, but it's not causing ketoacidosis. So both of these are going to be treated with insulin and fluid. DKA is generally going to be more complicated because we have to fix the acidosis that comes along with it. And I'm not going to get any further into it than that because for pharmacology, which is what we're doing right now, insulin and fluids is what you need to know there. Complications of diabetes. This is 100% your job to educate the patient on that. I don't know how much of this would be gotten into in a pharmacology course. This would be more adult health or med surg, but let's talk real quick. Complications include diabetic retinopathy. This is one of the leading causes of blindness in patients. So we have to definitely assess or make sure the patient understands, first of all, the significance of that. And second of all, make sure they're getting that annual eye exam. Next, nephropathy. That's where it kills off the kidneys. The vast majority, I'm pretty sure the number one cause of dialysis patients in this country is uncontrolled diabetes. So you have to educate your patients. They need to be compliant. If they are not, they can end up on dialysis. Not can, but likely will. Next, we have neuropathy. Again, this is a really big issue where the patient doesn't have appropriate nerve signals and sensation. And this can lead to amputations. One of the leading causes of non-traumatic amputation, if not the leading cause of non-traumatic amputations, that's those BKAs, those AKAs, the toe amputations, all of that is all from diabetes because they're not controlling it. So you have to educate your patients on that. Plus, obviously, atherosclerosis, peripheral vascular disease, heart attack, stroke, all of these things are all, unfortunately, very commonly seen complications of uncontrolled diabetes. Patients have to manage their disease. Now let's go in and start talking about the actual medication. So we start with talking about insulin, and we're going to spend the next little bit talking about that. I do have a chart here. It's broken down into 4 types of insulin. We have rapid-acting insulin, short-acting insulin, intermediate-acting insulin, and long-acting insulin. I put some common drugs for each of them. The rapid would be Lispro and Aspart. The short would be the regular, which is also called Humulin R. The NPH would be Humulin N, and the long-acting would be glargine and denomir. Next, I put the onset of these drugs. And this is very important to know because you'll almost for sure see this on any nursing pharmacology test. If a patient takes these medications, especially the first two, how soon after do they have to eat a meal? With a rapid acting, they must eat a meal within 15 minutes is the rule of thumb. If it's working within 15 to 30, they must eat a meal within that 15 minutes. You may see an even tighter restriction on that they need to eat within 5 or 10 minutes to make sure they don't forget and end up with other problems. With the regular insulin, they must eat within a half hour. Again, they have to eat within the lower range of that because if it's working within 15 to 30 minutes, they better be eating within that time. And they have to eat on the quicker end of that to make sure they don't have the insulin in their system without any food because then their sugar level drops and they can pass out and it gets worse from there. The next column that we have is how long these drugs last. So rapid acting lasts about 3 to 5 hours, 5 to 10 hours, 12 to 24, and 24 hours. And then I did put just a few notes for each of these. The rapid acting is generally used for meal coverage. So that's where a patient calculates either based on what their sugar is or what their meal is going to be, and they go ahead and they give themselves insulin based on that. Short-acting insulin, which is our regular insulin, our Humulin R, that's the most common by far that when we give IV in a hospital, such as for a patient with DKA or HHS. Intermediate acting, the NPH, this is also called isofin, so just keep that in mind. This is the one that's very famously cloudy. When you're giving this to a patient, you have to roll the vial in your hands very gently before giving it to stir up the contents. Don't aggressively shake it, but you do have to roll it for that reason. And this is one of the few times where we give a vial where the medication is cloudy or discolored, because generally that means throw the medication away. And finally, we have the long-acting, our basal coverage. And I will tell you one quick thing about basal coverage. When a type 2 diabetic, someone who's managed with metformin and all the drugs we're about to learn about, if they don't manage their insulin well enough, this is one of the first medications they get put on. Not only will they have to take their oral medications, but they're also going to have to take their insulin as well. And we usually start with the basal insulin. So what does insulin do? We already covered that. The mechanism of action, it takes the sugar into the cell. Sugar cannot get into the cell without that. And if it doesn't get into the cell, it stays in the blood. And then we have a high sugar level in the blood, which causes all of the problems that we talked about with the eyes, the kidneys, et cetera, et cetera. Next, we have what do we use this for? Obviously, we use this for diabetes. It is interesting to note, if you already looked at the fluid and electrolytes lecture, potassium, hyperkalemia. If a patient has acute unstable hyperkalemia, we actually give them insulin and sugar. Why? Because even though those cancel each other out and it won't affect their sugar level, if I give you insulin and sugar, the insulin and sugar together are going to walk into the cells out of the bloodstream. But every time they do that, I didn't previously mention this, they also take a potassium with them. So this works to get potassium out of the blood. Moving on, insulin is only available parenterally. We do have some intranasal options that are coming available. We don't have a PO option. It can't make it through the GI system successfully into the blood, at least as of when I'm filming this at the end of 2024. If anyone ever does invent oral insulin, they'll be a billionaire. Next, we have hypoglycemia as a side effect, hypokalemia as a side effect. Patients are often going to be on multiple insulins, such as a basal and a mealtime insulin. When you see the word prandial, that means related to mealtime. Just FYI, that means related to mealtime. Next, when drawing up NPH with a short acting, we draw up the short acting first. So you draw up the rapid, then you would draw up the NPH because we would want to combine them into the same syringe to minimize the amount of injections the patient has to get. Insulin is always stored at refrigerated temperature. Everyone knows that. However, once you open it and you're going to be using it, you can keep it at room temperature for up to 30 days, and then it must be thrown away after 30 days. Remember, we said when we're monitoring treatment, this is different than diagnosis, but when we're monitoring treatment, we want to target that A1C getting it below 7, and then we can give that patient a thumbs up that they're doing well. If the insulin causes hypoglycemia, we do need to treat that. We need to educate patients also about the signs and symptoms of that and to make sure they're carrying snacks with them so that if their sugar does get low, that they can get that treatment right away with some orange juice as opposed to having to go to the hospital or EMS for that IV glucose. Next, when you are educating a patient about diabetes in general, really every disease, but especially diabetes and especially about the injections and the hypoglycemia signs and symptoms to be aware of, make sure you're educating family as well. Make sure they know that when you're insulin-dependent diabetic and you're going to be getting injections on a regular basis, you should keep rotating the sites to prevent lipodystrophy. Patients that are type 1 diabetic or insulin-dependent diabetics should be wearing a medical alert bracelet. You do need to make sure that, like I said, they're aware of the signs and symptoms of hypo and hyperglycemia and when to report it to their provider. A sliding scale is something you're commonly going to see, especially in the hospital setting or patients that are complicated to control their diabetes. This is where a patient is, let's say, scheduled that every breakfast, lunch, and dinner, they take a dose of insulin based on their meal that they're about to eat. We give them a sliding scale and we tell them, you're about to take some insulin, so you're about to get yourself stuck anyways by the subcutaneous needle. Let's go ahead and let's see if we can get this perfect. Check your sugar right beforehand. And if your sugar is high, let's go ahead and give you a little bit extra. You're giving yourself anyways. Let's give you a little bit extra to try to get that sugar down to exactly where it should be. Because again, we're never going to be able to perfectly do what the pancreas under healthy circumstances does. So we're trying our best to mimic it. So instead of the patient just taking their 3 units of insulin based on the meal that they're about to eat, let's check their sugar. And if their sugar is high, then based on a sliding scale, they're going to give themselves more. So in our example, if they're supposed to get 3 units based on the meal they're about to eat, they check their sugar and they're going to look. If let's say their sugar was 250, they look at the sliding scale. The sliding scale says for a sugar 150 to 200, add 1 unit of insulin. For sugar 200 to 300, add 2 units, and so on and so forth. I'm making up these numbers. They're all different. But that's what a sliding scale is, and that's how you would use it. Generally speaking, we always have a patient check their sugar before giving themselves a dose of insulin because we can never risk getting it too low because a patient can die from hypoglycemia. IV insulin is considered a high-risk medication, and we generally only do that in ER, ICU, or other acute care settings. Now let's get into the oral and all the chronic medications that we have for type 2 diabetes. So we start with the biguanides, that's metformin, that is universally considered the first-line drug for the treatment of diabetes. It's a PL medication. It blocks glucose production in the liver, and most importantly, it increases insulin sensitivity. So instead of the cells being insulin resistant, they become insulin receptive. They are happy to let the cell in, the sugar into the cell. What do we use this for? Obviously, we use it for diabetes. We also use it off-label for PCOS, polycystic ovarian syndrome, and we in order to help with fertility in patients that are suffering from infertility-related PCOS. It does have a black box warning that can cause lactic acidosis. It does have a very, very, very well-known and infamous adverse effect of causing GI upset, specifically diarrhea. You do need to educate your patients. Almost everyone that starts metformin is going to get diarrhea. However, if we didn't give them too high a dose, or if we didn't start them too fast or something like that, if we started them appropriately and we're titrating it up appropriately, you should educate them that it's just for a few days, a few weeks tops, and their body will get used to it and they won't have that bad diarrhea for the duration of the treatment. If you don't educate them about that, they're going to take the medication. 2 days later, they're going to say, I'm done with this because I have diarrhea. I must be allergic to it or something like that they don't know any better if you didn't teach them. When a patient's taking metformin, they should avoid alcohol. And this is the universally considered first-line agent for diabetes. Next, we have the GLP-1 agonist. The GLP-1 agonist, very famous over the last 2 years, roughly. Right now, we're filming this at the end of 2024. And that's because Ozempic and some of these other drugs have gotten famous for weight loss. But today, we're talking about diabetes. So the GLP-1 agonists include Ozempic, includes Trulicity and Victoza. The pronunciation for these drugs are semaglutide, dulaglutide, liraglutide. And these medications work by increasing the effects of insulin, which stimulates the release of insulin and blocks the release of glucagon. So these are both going to be things that are going to help lower the sugar level by getting more insulin out there and by getting less sugar out there. What do we use it for? Obviously for diabetes, and some of these are actually now labeled officially to be used for weight loss as well. It does have a black box warning that it can cause thyroid. It has an increased risk of thyroid C-cell cancer. It does have side effects of GI effects as well as a higher heart rate. This medication is by injection only, as opposed to almost all the rest of the type 2 diabetes medications that we're about to talk about. This is the one that's by injection, so you probably should know that's a good test question that needs to be asked. And this is very often used as our go-to next line agent if the metformin is not getting the patient down to their target A1C. I should give you a heads up. I didn't mention this previously. If a patient is getting a medication for type 2 diabetes, let's say their A1C comes back at 10, metformin, even at max dose, is really only going to get their A1C down roughly 2 points. They really need their lifestyle modifications or other medications to do the rest, ideally the lifestyle modifications. But metformin is not going to get you from a 10 down to a 6.5. It's just not powerful enough to do that. So if we do need to add another medication, the GLP-1 agonist is very often our second line recommended. The big downside to this, it's by injection, so a lot of patients have a problem with that, even though it is just a once a week. The really big issue is that this is a very expensive medication. Generally, as of today, if patients don't have insurance for this medication, it usually runs about $1,000 a month. Next, let's talk about sulfonylureas. In some parts of the world, this is actually considered the go-to drug instead of metformin. And this would be glipizide. It's been around a very long time. It stimulates the release of insulin, more chance of the insulin getting into the cell and out of the bloodstream. The indications are for diabetes. This one can drop your sugar level too low because it doesn't have that built-in, it overrides the built-in control that your sugar level shouldn't get too low. So these patients definitely need to be educated to make sure to carry snacks with them and not get themselves in a bad situation. This also has the unfortunate side effect of causing weight gain, which in almost every diabetic patient is a problem. Also, this medication can definitely not be combined with alcohol, or they will get an antabuse-like syndrome. Next, we have the meglitinides, such as repiglinide, and this stimulates the release of insulin, same as the last drug did. This one also works for diabetes, and this one also, for the same reason, has the adverse effect of hypoglycemia. This one should really be taken with food to make sure we really don't get into that hypoglycemia, and of course, educate your patient about that risk. The next drug class, I can't even pronounce it, so I'm not going to try, but the brand names here are Avandia and Actos. I can pronounce that. The mechanism of action is that increased insulin sensitivity. Again, we said that's the core problem in type 2 diabetes, and that's what we use it for. It does have a side effect of weight gain, so that's something to consider. It has a black box warning that it cannot be used in a patient that has heart failure because it can exacerbate it, and any patient who's at risk for developing heart failure also probably should not get it due to that risk. It does have a whole bunch of other contraindications, such as pregnancy, high risk for fractures, so let's say postmenopausal woman with osteoporosis, as well as acute liver failure. Next, we have the DPP-4 inhibitors. This would be Tradjenta and Januvia. These medications block the breakdown of incretin, and incretin, we've already said, gets us more insulin and less sugar in our blood, and we use this for diabetes. I don't have anything more to add about that one. I don't know that any nursing school textbook got too deep into these as we're getting further down this list. Next, we have the SGLT2 inhibitors. These are dapagliflozin, which is Farxiga, it's Jardiance. These work different than all the others. These get the body to simply pee out extra sugar. So it dramatically increases the amount of sugar that's excreted through the kidneys. It also has cardiac benefits that it increases preload and afterload, which is why this is becoming one of the go-to drugs for heart failure. And if you watch the heart failure lecture, we discussed this. What do we use this for? We use this for diabetes, for chronic kidney disease, as well as for heart failure. It does have a common side effect that in females it can cause UTIs, but it does have a beneficial side effect that it is known to cause weight loss, just like the GLP-1 agonists. And the last drug we're going to talk about, not very commonly used, just like some of these other ones at the end, but alpha glucosidase inhibitors such as acarbose. This one slows the digestion of carbohydrates so that the body doesn't absorb as much sugar from our meals. This is again used for diabetes, and because of the mechanism of action of how it works in terms of messing with our digestion, it can cause GI effects, and patients should be educated to take this at the start of the meal. Please go ahead and subscribe. Let us know if you have any questions, and have a great day.